Let me tell you a story of how I became interested in wellness and prevention. In 1970, I was a newly minted professor at Caltech, interested in human biology, but kind of staggered by the complexity of it, and realized at the time there weren't good tools for dealing with data. And I think there were two things that were really important. Is one, the only way to really deal with complexity, at least at that time, was to generate enormous amounts of data in humans, and two, there weren't good tools for doing it. And this set me on a path that included 4 paradigm changes that I'll talk about. The first was developing 6 instruments, including the automated DNA sequencer, that allowed one to read and write DNA in various ways. The automated sequencer got me invited to the first meeting ever on the human genome, and I got very engaged in that, and that led to all sorts of possibilities we'll talk about shortly. Third, I had been thinking for about 15 years about how to analyze complexity and started articulating basic principles of systems biology, and that led to the Institute for Systems Biology in 2000, and finally in 2014 and 15, started the first studies on precision population health with a focus on wellness. And that's kind of where the story starts. And we'll talk about how we've now moved to a point where we can really think about catalyzing a shift from our current disease care to wellness and prevention. So, why health? I mean, it's an obvious question. I think the fundamental idea is health is the basis for human creativity, normal development, learning, happiness, and a whole variety of things, and it's obviously very, very fundamental. And health in the best sense of the word, I mean. I started thinking a couple of years ago about when did our concept of health really first start. And what was interesting is it started with the Greeks. There's no history before 2,500 years or so ago, but what the Greeks thought was involved with health was fates, the self-behavior, and the environment. And it turns out they were right spot on, especially if you change fates to the genome. And I would argue that the one thing that's happened in the subsequent 20-some centuries that has really changed how we can think about health and what it really is a data-driven approach to individuals. And I'm going to try and convince you as to just why that is so. And finally, I would argue again that although I didn't realize it back in 1970, what is critical to a data-driven approach to health is using systems biology to come to understand all of that complexity. And of course, this systems approach to health, the key point is that blood is a window into wellness and disease because it bathes all organs, and those organs secrete molecules whose concentrations change, and if you can read those concentration changes, you can assess in all of the major organs of the human being how things are at a given point in time. And of course, those quantitative figures get changed into data, and the data then can be moved into biological networks that underlie the physiology and the disease process and so forth. What exactly is data-driven health? And I would argue for us, it's all about doing the complete genome sequence and the longitudinal phenome, and we'll chat about that in just a moment. And I'll give you 3 points of validation for data-driven health for body, for brain, and for gut. And let me say, I think brain is one of the most ignored aspects of health in contemporary medicine today, and we'll talk just very briefly about what we're going to do about that. So what we're going to talk about later is a very large project. I call it a second genome project, which is called the Human Phenome Initiative, where we propose to do 1 million people over a period of 10 years. And the human phenome, of course, is our appearance all the way across our lives. There are 1 million different phenomes, and they change radically. And what is the basis that encodes that radical change is the genome, your self behavior, and your environment, just exactly what the Greeks said, more or less. And the assays we're using to do these, as I hinted earlier, are blood analytics, proteins, metabolites, clinical chemistries, are the gut microbiome, are various modes of digital health, both for body and for brain. And the proof of principle for this whole idea is a company I started with Nathan Price in 2015 called Aravale, that over a 4-year period collected 5,000 individuals, and we did phenome analyses twice a year during that period of time. So we had longitudinal data clouds for each individual, and they drove us to this science of wellness and prevention, and you'll come to understand that. Number two, we're partnering now with a company called Posit, the brainstorm of Michael Merzenich, who can use digital assessments, some 40 of them, to assess 25 different cognitive features, but not only assess, if the cognitive features are deficient, he can actually reconstitute to a certain extent those cognitive features, even in 80-year-olds. And finally, the gut microbiome, the microbes present in your gut that have a profound impact on health. We've also looked at those from the Aravale 5,000. And what I can tell you is the Aravale has led to almost 30 papers in the last 7 or 8 years that define various features of wellness and prevention. And I'm going to talk just about several of these. Okay. Your advance is not advancing well. The first of these is really important because what we were able to see in the 5,000 people was 167 cases where the individual transitioned from wellness to disease. We took 10 cases where the transition was to cancer, and we looked at bloods prior to the clinical diagnosis, and we looked at proteins that were off scale compared to the normal population set that existed at that time point. And what we were able to demonstrate for every single one of those 10 cases is there were abnormal proteins, enormously increased in concentration generally, that marked the earliest transition between 1 and 5 years before the actual diagnosis. So it means we have the ability to be able to detect early transitions and think about multimodal therapies we can use to reverse disease before they become clinically manifest and when they are at a simplest level of their exposition. Point number 2 was fascinating. With the first 100 people we analyzed, we were able to look at the 6 data types and determine statistical correlations between them. And we saw 3,500 such correlations. And these turned out to be a fuzzy hairball of statistical correlations. But if you used an algorithm that operationally cleaved the edges that had the lowest probabilities, they deconvoluted into 70 communities of those features that correlated beautifully with physiology and or with disease. And you can see some of the examples of ones that we had. And when we looked at one disease, one community correlation, that is for cholesterol, we saw that there are 12 analytes, and one of them, thyroxine, had a profoundly negative correlation. And it turned out that this proposed drug was actually at the time being tested by Lilly. And so what we next did was to take the same 100 patients and look at 5,000 proteins. We got 35,000 correlations. We got hundreds of communities, and virtually all of the original communities expanded enormously in the number of correlations. So this is an incredibly powerful new approach for drug discovery and so forth. The gut microbiome, obviously, is very important, and what we did here was to take 9,000 individuals, starting at 60 years of age and going through 88 years or so of age, and follow their gut microbiomes on a regular twice-a-year basis. And what we were able to show beautifully is for people that aged in a healthy manner, two things happened. One, they lost the core taxa that were present in the 20s and 30s. And two, they developed uniquely individual microbiota. Each of them did differently. Whereas if you were unhealthy, you neither lost your core microbiota, nor did you evolve a uniquely diversifying gut microbiome. And in fact, what we were able to show beautifully in the cadre that was in the 80s, that the individuals that were unhealthy were 4 times as likely to die as those unhealthy. And this opens up the possibility of manipulating the gut microbiome to optimize a healthy aging in really interesting kinds of ways. There are really 2 kinds of wellness: traditional wellness that you've all heard about, many companies exist, and the data-driven wellness, which create actionable possibilities. That is, from statistical correlations come opportunities to do things that either improve wellness or avoid disease. And we can get them from the genome. And what I'll point out at the genome is there are of the order of 600 variants that correlate with various physical deficiencies, like the ability to tear ACLs very easily. And if you know you have those deficiencies, you can actually do exercises that will block them. And we can look at the phenome and get actionable possibilities, or we can integrate things together. But the really important point is that the data-driven scientific wellness, when fed back into traditional wellness, can give you unique trajectories that each person should follow with regard to diet, exercise, sleep, and stress management. So the two beautifully work together. The vision, actually, I think is a really important one because it asks the really fundamental question, what exactly is health? And then I'm going to show you about Phenome Health and the initiative I talked about. So the data-driven vision is essentially assessing and optimizing the health trajectory of each individual. And the health trajectory, of course, is what happens to you along your entire lifetime. There are 3 different transitions. Most of us start in wellness. We can undergo a transition to disease, which progresses, generally resolves, and takes us back to wellness. And we've actually shown in 2 mouse model systems where we can induce at will the disease, prion disease, a neurodegenerative one, and glioblastoma cancer, that from the point of induction, there is a beautiful exponential increase in disease-perturbed networks that are deficient, that grow increasingly in their complexity. And the other point I'm going to make is that for most chronic diseases like cancer or diabetes, you have multiple subtypes of these things, and that's the first thing you should define. And then once you've defined a subtype, you can define the nature of that particular subtype trajectory. So it's important to say we can deal with wellness, transitions, or disease in interesting ways. Most of you probably reach 20 to 30% of your potential wellness. And we can increase that enormously just with the hundreds of actionable possibilities we've already defined. One of the really important questions is, do you have the will to really push to do that? And where it's important is when you get old, okay? Because you'll be in much better shape then. With transitions, we can already begin to see, by using multimodal approaches to cancer and other transitions, we can begin to think about therapies. And what is really attractive is the idea with this kind of data-driven health that you could pick up most transitions to most chronic diseases and reverse them before you get the disease. And of course, with disease, you can define subtypes, you can define transitions within a subtype and use the classic precision of medicine and everything. So health really has these 3 features: wellness, transitions, and disease. And I would argue this is the greatest paradigm change ever if we can move to a wellness and prevention mode in the history of medicine. So what's next? It's this Human Phenome initiative. I started 2 years ago, Phenome Health, which is a nonprofit that is driving this human initiative, and will talk about its 2 features. In the short term, what we plan to do is take the 4 major chronic diseases, starting with diabetes, and doing intense data-driven analyses of each of them over extended periods of time. And I'm going to define that in a little more detail in just a few minutes. And in the longer term, we hope to have the Million Person Project funded by the government, just as we did the first Human Genome Project back in 1990, over a period of 10 years or so. Where are we in Phenome Health now? Well, we've generated a partner guardian research network which has access to 50 million patients. It's learned how to translate their electronic health records into both structured and unstructured data. So with their very complete electronic health records, they've been permissioned for clinical trials, so it'll be easy to get things started in that population. And what's important is the 150 hospitals that they represent are all community hospitals, and the patients are sticky. They stay their entire lifetime with a single institution, so we have electronic health records that go back to the beginning of whenever they started to make that. A second partner is BrainHQ. It's the digital assessment of brain cognition. That's going to be a fundamental part of what we're doing. We hired a marvelous, very small company of software engineers that has built us a combinatorial platform that essentially carries out all of the procedures we need for these multi-omic analyses, and we're actually going to probably be using that in the context of partners that we're accumulating right now. We've had a 2-year interaction with Google, and there we see using search, cloud, digital health, which is the Fitbit, and hyperscale AI, which is essentially the ability to do combinatoric analyses at 6 or 8 orders of magnitude greater than what most academics have access to. It's an aspect of the current rage that's out there. ISB has taught us how to use knowledge graphs and how to use digital twins, and I'll say more about those in just a moment. And Scientific American actually has just published an 80-page issue on the new science of wellness. And this is a terrific teaching tool for physicians and for patients themselves. And we've raised the money to be able to do various things. So we're going to do blood analytics, and I won't run through all the different things we're going to do. But we figure we'll generate at least 1,000 times more data than we did with the initial individuals in the Airvale population. We're going to do the brain assays, we're going to do microbiome assays, and we have several metrics that we'll be using at every blood draw. We have a beautiful biological age metric that uses metabolites and makes recommendations about how to optimize not only globally how you age, but how major organs age as well. And we've just defined a metabolic BMI that is far better than the physical BMI that we'll be using to assess metabolic state and so forth. Self-tracking with Fitbit and possibly other devices. Electronic health records are a really important part of initial phase of clinical trials. And then the social determinants of health and self-reporting. And we're doing whole genome analysis for every single individual patient. What's next in the Human Phenome Initiative then? Well, again, it's this idea of a data-rich observational series of studies starting with type 2 diabetes and generating all the kinds of data that we talked about here that will lead to vast conclusions. And the essence of this approach is a threefold tack. We'll use, and we have finished with this almost, 10 million electronic health records that have 11% diagnosed diabetes, have about 30% prediabetes, and the rest are normal. And what we're doing with those is looking for clinical markers to define the subtypes of diabetes, which there are supposedly 4, and then to follow the transitions within the subtype we're most interested in, the one leading to chronic kidney disease, which costs the healthcare system enormous amounts of money. So we have markers now then that will allow us to pile the patients up, 250 at each of the hypothetical 4 transition points. And then we'll move to the second prospective trial where we'll do the very dense data analyses, including deep immune analyses where at each blood draw we analyze at the single cell level the transcriptomes, cell surface proteins, and secreted proteins. And it gives us an integrated state and comparison of adaptive and innate immunity beautifully, which has never been done in a clinical trial before like this. And once we learn about subtypes and transitions and so forth, then we can think about trials that are interventional, optimizing the biomarkers for key transition points and drug targets and the like. So, let me talk briefly about hyperscale AI and the individual patient data analyses. So just to put things in context, we're going to be using 2 knowledge graphs, one from Google, which has 50 billion nodes and 850 billion edges. And of course, the nodes are things like genes and proteins and gene and diseases and so forth. And spoke, which is something that came out of UCSF that is much, much smaller, but it's enormously more detailed in its delineation of features and everything like that. And to show you the kind of data that we have to worry about, from the first time point we take a patient in the diabetes trial, the genome will be 120 gigabases. The phenome is very small. The microbiome, 100 gigabases. Digital health is as large as you want to make it, basically, and single cell analysis is hundreds of gigabases. So we need the platform that we created to be able to deal, obviously, with this kind of data. So beyond big data, how do we unite that with big knowledge in hyperscale AI? Well, that represents the individual patient data that we'll be generating, and the traditional approaches that we used were classic statistical analysis, which allowed us to do the correlations that led us back to the literature that gave us the actionable possibilities. But what we plan to do is the two types of knowledge graphs that I've defined there, and they will both be fed into a digital twin we're building for type 2 diabetes. So from the top down, the digital twin, we put in all of the mechanistic generally differential equations that have been developed together with the physiology of the disease. From the bottom up, we'll add all the omics and biochemistry and clinical chemistries we have on type 2 diabetes. And what is really key is we'll add all of the patients that we acquire, their data to the digital twin as quickly as we can. Now, what those things together do is set a context for the hyperscale AI so that it can operate in the right territory to make detections about the individual's own patterns and losses and abnormalities in a way that's not been possible before. And indeed, there are some that argue with the kind of comparisons that can be made and the level at which they can be made, there may be a possibility in the future you're not just going to end up getting statistical definition of correlations, but to lead directly to mechanistic and causal explanations. And of course, this is an enormous debate. But I think putting type 2 diabetes into this will absolutely transform how we deal with individual patients in the future. So let me just say the final thing I'll talk about is a systems approach to healthcare, which we thought about in the early 2000s, ended up arguing that it should be predictive, preventive, personalized, and participatory, or P4 medicine. And what is interesting about P4 medicine is the first three Ps are science, and I really think we know how to do the science. The fourth P is participatory, and that involves psychology and sociology and economics and education, and I think this is the challenge. How do you persuade the patient, the physician, the healthcare leader, the healthcare technologist? How do you persuade the regulators? How do you persuade the payers, the politicians, and all to buy into this kind of thing? I think there's frankly only one solution, and we're not really going to have time to talk about it in detail, but I think that the kind of medicine I've talked about here, prediction and prevention, is going to save trillions of dollars in money, and it's going to make prevention and wellness more profitable than disease. That sounds like a radical statement. We've done a whole series of things on the education. We've written a textbook on systems biology and systems medicine, and I hope medical schools will adopt it, although I have to say I'm really skeptical. I think medical schools are unbelievably conservative and unwilling to think about much of anything that's very new. And I can tell you, I went to Hopkins, my alma mater, 3 different times trying this, and I gave up finally. We initiated with a group of 8 wonderful educators I created at the Institute for Systems Biology based on this textbook. A year-long 20-module course on systems and P4 medicine for high school students. And I'll guarantee you, if they come out of that course, they'll know more than 95% of the doctors will about medicine in the future. And we're actually going to adopt that course for weekend teaching of physicians. And I hope it won't be too difficult for the physicians. Wrote a popular book with Nathan Price during COVID times called The Age of Scientific Wellness, which talks about all the things that I've done here, and that's going to be available from Harvard University Press in April. I've written a bunch of op-ed pieces for the Times, and we're doing a 90-minute documentary on wellness over the last 5,000 years called The Phenome Age, A Quest for Wellness. And it's done by a terrific Italian director who is a real artist. And then I mentioned the partnership with Scientific American, funded actually by Google, on this new issue of the new science of wellness, which is a great place to start if you want to learn about all of this. So what exactly is next then? This million-person project is what I really hope to get going in the next few years. And if we have 1 million people over 10 years, we'll be able to answer, I think, all 5 of the fundamental challenges healthcare faces today: poor quality, aging population, explosion of chronic diseases, racial inequities, and finally the escalating costs. I think all of those will have a solution beautifully in the Human Genome Initiative. Thank you.
Thank you. Wait.
You want to ask a question?
One quick question. We're about to go to dinner, but one quick question. Don't leave quite yet. If you were to give this amazing audience here online one sort of mission to get to next, you've been a great instigator from P4 medicine, systems biology. Any scintillated synthesis of how to get to next that you've taken away from your experience?
I think in the end, the key to everything has been systems thinking. Mm-hmm. It's the key to the science. It's the key to the education. It's the key to the organization. Every way you look, you see systems thinking and systems approaches are going to be the solution. So my advice is to apply this freely to everything, and things begin to fit together and converge in very beautiful ways that way.
And I think that's the theme of this community. It's convergence to system thinking. It's no one technology. It's bringing it all together. Before you go, since you've been such a disruptor, and we have the special Medical Entrepreneurship and Disruption Award, the MEDI, we have a special MEDI Award for you as key disruptor for our age. Leroy Hood, let's give it up.
Oh, thank you.
Thanks so much.
Thank you.
MEDI Award.
Thank you.